Yeah, so I'm going to give the last talk on this and try to advocate why LAA occlusion in structural heart disease such as TAVI and mitral intervention is a way to go forward. So for you who's not working with TAVI every day, I'm just going to give you an update. Where are we with TAVI today? The first implant was done back in 2004 by Alain Crébier in a very sick patient. And at that time, there was discussion whether TAVI actually had a place in these extreme risk patients. But the Partner B trial showed that TAVI, compared to best medical treatment, actually reduced one-year mortality from 50% to 30%. So I think that's out of the question. If you choose your right patients, TAVI is a very good treatment for a patient who's not suitable for surgery. Next question was, of course, what if you go to patient at high surgical risk? And the CoreValve US trial showed for the first time that TAVI was actually a better treatment for patients with aortic stenosis than surgical aortic valve replacement. So lower mortality rate after 1 year, and it's actually consistent up to 2 years after the procedure. But most of the patients with aortic stenosis is not at high risk or extreme risk. They are at intermediate risk or at low risk. And there's 2 trials being conducted on intermediate risk, Partner 2, which is hopefully going to present it at ACC next month, and Medtronic's TAVI trial, which is going to be presented a year later. But we in the Nordic countries actually conducted a low-risk trial, the NOTION trial. So if you try to classify the low-risk patient as a patient who had an STS score that less than 4%, we in the NOTION trial actually had more than 80% of the patient in the trial having STS score less than 4%. So this was actually a true lower risk TAVI cohort, randomized between TAVI and surgical aortic valve replacement, 280 patients, and there was no difference between TAVI and surgical aortic valve replacement, even in low risk patients. So I think everyone who's working with TAVI foresee within the next years, 5 to 10 years, TAVI is going to replace surgical aortic valve replacement for far the majority of the patient with aortic stenosis. One of the questions people are asking nowadays, what is the durability of the TAVI valve? It's going to take several years before we have 10 or 20 years follow-up, but we in Copenhagen try to compare our first 600 TAVI patients. We match them with 20 patients, 20 subjects, same age, same sex, and same region of living in Denmark. And we could see if you set a landmark after 3 months, so you eliminated the procedural risk, you can see there was no difference in survival up to 7 years after the TAVI procedure. And you already now see that the TAVI population across Europe and the same with North America, Japan, Australia is going very, very quickly up. So this is a high volume procedure. But what about TAVI and stroke? We know, of course, there's a stroke rate associated with the procedure itself when you manipulate around in the calcified aortic annulus. But also you can see it's a continuous risk. It's going up about 5% a year. Patient will continue to have a stroke. In the beginning, there was a question whether the stroke rate was higher for TAVI than surgical aortic valve replacement. It's not true, but there's still a significant stroke rate in these patients. And you can probably divide the stroke up in 2 parts, what's happening in the cath lab and the few weeks after the procedure, and what's happening in the long term, probably due to atrial fibrillation. What happened in the cath lab, you can use cerebral protection devices, try to capture the debris which is coming off the valve during manipulation and valve implantation. And also, it's been described that during the first couple of weeks, the first couple of months after the procedure, you don't really see tissue ingrow on all the stent frame, which can also be a substrate for thrombosis and stroke. And we was part of a report last year also showing that you can see some probably thrombus formation on the leaflets, which cause reduced leaflet motion in all aortic bioprosthesis, not only TAVI procedures, but also surgical prosthesis, which may be a substrate for stroke. Even though the patient is asymptomatic, you can't measure any increased gradient, there's no symptoms, this could be a substrate for stroke. In the NOTION trial, we did a sub-study In 80 patients, we implanted a reveal unit, 50% within the surgical cohort and 50% in the TAVI cohort, to see how many patients actually had episode of atrial fibrillation after a TAVI procedure. And you see, for the surgical cohort, all patients had some episodes of atrial fibrillation after the TAVI, the procedure, the surgical procedure. And for the TAVI, it was 80%, 80% of the patients had episodes of atrial fibrillation after a TAVI procedure. And the mean average of this was about 30 minutes. So for sure, this is an unrecognized issue after TAVI. And does it matter? Yeah, for sure.